This is Emily Walker, MedPage Today, reporting from Washington. I'm here at the National Press Club, where the policy journal Health Affairs held a briefing on ways to improve the primary care system. I spoke with Dr. Larry Casalino, who's a professor at Cornell University, and he was a former primary care physician for 20 years. He shared with me his vision of how to improve the primary care system, and the main component of that is to completely reorganize how a physician spends his or her day.
If a Martian landed and looked at the way primary care physicians spend their day, it would look crazy to the Martian. I think Martian would say, let's go back to the drawing board here. We have these highly trained, highly motivated people, and we need to think about what's the best way for them to spend their time, and it probably isn't chaotically running from patient to patient as fast as they can go.
Before he went to medical school, Dr. Casalino worked on an assembly line where he would pound corks into vodka bottles or load the bottles onto pallets at the end of the line. He had no idea working as a primary care physician would be so much like that.
I have worked on assembly lines prior to medical school. I know what that's like, and I had no idea that being a primary care physician would be like that. But I mean, when I was working on an assembly line, you couldn't go to the bathroom. I mean, you had to wait to break time. And as a primary care physician, literally there was no time to do that kind of thing much of the time. I really did feel that each day that I was going to kind of Armageddon, that each day I had to be just at the top of my form to get through intense multitasking with a lot of time pressure, and it just need not be that way.
In his paper titled A Martian's Prescription for Primary Care, Overhaul of the Physician's Workday, published in the May issue of Health Affairs, Dr. Casalino laid out a less assembly line approach to treating patients.
Most of the patients who primary care physicians see probably don't need to be seen in person. There's a lot of upper respiratory infections, low back pain, routine checks for blood pressure, routine checks for diabetes. Probably no need for those people to take off for work, get a babysitter, drag the kids into the office, lose a half a day, to be seen for something that could be done very easily over the telephone or by email by the physician or sometimes by a non-physician staff in the office. So my guess is there's probably about, instead of 25 or 30 patients a day that a primary care physician needs to see, probably the correct number would be more like 8. These would be people who this was their first visit, or they had very complex problems, emotional problems, or something physical needed to be done. For some reason their heart really needs to be listened to, or a joint needs to be injected. The rest of the people, again, could be dealt with by email, phone, or other means.
By cutting out the non-essential face-to-face time, the primary care physician could have longer in-person visits with the patients who need it most, Dr. Casalino said.
And it would enable primary care physicians, I think, to have much more satisfying, and their staff, to have much more satisfying work days, and also to take care of a lot more patients each day and to provide better care from population of patients. So I think it'd be better for the physicians, better for the staff, much better for the patients, increase quality, reduce the cost of health care, and greatly save patients' time.
But primary care physicians might get paid for office visits, but not for calling patients on the phone, and that could be a deterrent to adopting Dr. Casalino's model. But he says he doesn't think doctors should be reimbursed for making a phone call or sending an email, because that would be turning medicine into an assembly line once again. I
wouldn't reimburse people directly for making a call or for doing an email. That just perpetuates this assembly line system of, get paid for doing this, and this. I would pay, actually very much like the Danish system that we heard about from Paul Grundy, where about 1/3 of the pay is actually based on performance of various kinds, patient experience, providing certain levels of access and so on and so forth, as well as performance on some quality measures. And then 1/3 would be capitation. You get this much per patient per month, risk adjusted for their illness, for each patient who's your patient. And 1/3 would be fee-for-service as we see it now, not for every phone call and so on and so forth, but for actually seeing the patients face-to-face who need it. And so if you're a primary care physician, your financial incentive, you don't have an incentive to make the patient come in because you're getting paid in 2 other ways, not just for making. On the other hand, if you do have a patient come in, you do get some money for that. You're not penalized for it like you are in a straight capitated system.
Dr. Casalino's model was one of several presented at the Health Affairs Primary Care Briefing, which was kicked off by Health and Human Service Secretary Kathleen Sebelius. From Washington, I'm Emily Walker, MedPage Today.